Hi everyone. Apologies for the loud AV. It turns out you may notice that we don't have our usual setup and the screens are not working. It's because the device that controls the AV in this room was pilfered. And so no one can access the controls without that device, and so we're left to kind of, whatever you would call this, 20th century technology. But it's working. Those of you in the back, I'm sorry if you want to try to move up. There aren't really that many seats, but it's going to be what you see here. So sharpen your eyes or crane your necks or both. So it's a pleasure to welcome you all and to remind everybody, in addition to this being one of the bi-weekly Berman Institute seminars, this is also one of our semi-annual Hustler Reeves lectures, which you, if you've come to them before, will recall are devoted to topics related to palliative care. And just as a quick bit of background about the naming of this lectureship, I will recount to you just a little bit of the history. The lectureship was actually endowed by Eleanor Trowbridge, who was a member of the advisory board of the Berman Institute until she passed away in the year 2007. She was a devoted Hopkins person and a really close friend of the founder of the Berman Institute, Ruth Faden. She made a bequest to the Berman Institute to establish this lecture series named in honor of her daughter, Sheila Hustler Reeves, who died in 1988 from breast cancer. Over the course of Ellie's time associated with the Berman Institute, palliative care was an issue of great importance to her, and we're pleased to be able to continue the conversation on this topic with this lectureship. It's my pleasure to welcome Christine Mitchell to give the Hustler Reeves lecture for the spring of 2018. Christine is Executive Director of the Center for Bioethics and a senior lecturer in the Masters in Bioethics and Bioethics Fellowship Program at Harvard Medical School. She's a longtime friend and colleague. We were actually talking about some of the shared and remembered history of our both participating in bioethics over the course of, I would say, years, probably decades, is more accurate. She founded the ethics program at Boston Children's Hospital, where she directed the ethics consultation service and continues to do so, and leads the ethics advisory committee for 30 years. I could say more. I won't, except to say we're really privileged to have you here today, Christine. And as you all can see from the slide on the screen, Christine's talk today will be about end-of-life bioethics engaging the public. Please join me in welcoming Christine Mitchell.
Good morning, good afternoon, good evening. This clock is right twice a day. It's either the right hour or the right minute. So when I'm getting close to 45 minutes, if you give me a little high sign, that would be great. Let me check and see first who's here. How many of you are members of the general public? That's everybody, right? And nurses, physicians, social workers, chaplains, people who specialize in palliative care. What did I forget? Other? Thank you. It's always helpful to know who you're talking to. So as you know, my background is as a nurse and as an ethicist, specifically in clinical ethics. And one of the things we did in the early days of setting up the clinical ethics committee, it was called the Ethics Advisory Committee at Boston Children's Hospital in 1984, was to think about how we were going to involve some members of the public as, quote, community members, serving on the Ethics Advisory Committee and all the complexities associated with having people who are not part of the health professionals and on the staff and employees of the hospital. And part of the discussion that we had at the time, although we didn't solve this problem for a very long time, was how can you invite somebody to be a community member of a functioning clinical ethics committee that's doing ethics consults in addition to policy and education and some research, when you only got like 1 or 2 spots? They can't represent everybody. And not only that, it's a little intimidating to be talking to some of the people who are on the ethics committee, which did turn out to be true. Getting them to say anything was our first challenge. And it was our effort to solve this problem that led to setting up a community ethics committee, which is what I want to talk to you about, and the work that they have done on issues in taking care of patients toward the ends of their lives. So I'm going to describe what we have called for now a number of years our Community Ethics Committee, even though I didn't put that in caps because we mean it to be both uppercase as its name and lowercase as a model for what anyone might do in trying to make a more robust system for engaging the public in discussions about healthcare at the end of life. So I'm going to describe a method of public participation that we've developed specifically around ethical issues that come up in hospital policies around end-of-life care. And I want to talk with you about identifying what those ethical issues in healthcare decisions at the end of life might be, and where it would be helpful to have healthcare providers and clinical ethics committees get community or public input, and where it might be helpful for the public to have more information about the kinds of decisions and policies that hospitals are involved in. And then lastly, I want to talk to you about some of the challenges, any of which we have not solved, in obtaining useful public input in clinical bioethics. So I want to talk with you about a process that sort of give you an example of how this comes up by describing our next to the last request that the Community Ethics Committee got. And then I'll tell you the process about how that request comes and where it goes. So the nurses who were at the front lines, and even more specifically the nurses' aides, can't believe I didn't put that in there, I should have. The nutritionist, the dietitian, and one of the physicians from long-term care residence facility that is part of the Harvard Teaching Hospital system came to the Center for Bioethics to ask for the opportunity to talk with us about a policy that their clinical ethics committee was developing about patients who want to stop eating and drinking. So these are people who have had some health challenges and who are living until the end of their lives probably in a long-term care facility, and they progressively decline, but many of them start off reasonably physically and often but not always mentally healthy. And they had had a number of occasions where there had been questions about what to do when a resident refused to eat. And over the past few years, that had kind of settled itself down case by case as residents had changed their minds or declined for other reasons, where refusing to eat had become the sort of pivotal ethical question in their care until recently. And so as they talked about not only their past cases that came up again in discussing their current case, the Clinical Ethics Committee decided, you know, we really have to think this through institutionally and figure out how we're going to handle it. And, you know, of course, a number of questions came up in their discussion. To what extent is a resident making an informed decision? What do they realize is at stake here? You know, it's one thing to say you can't live if you don't eat or drink, but it's another to think through the ramifications day by day. And it's also a matter of thinking about the ways in which these residents are particularly vulnerable. So as they talk to us, perhaps this wasn't part of their internal ethics committee discussion, the way that some hospitals solve this problem is by transferring the ethical dilemma with the patient, right? And therefore someone else has to deal with the patient who doesn't want to eat and drink and who also sometimes says they just want to die. And if there are conscience qualms among the people in the hospital when this happens, they simply move the patient. And it's not as though you can't think about that in a long-term care facility, but remember, you're moving a person out of what has become their home. Because this is where they expected to stay until the end of their life. So, you know, the obvious vulnerabilities are things like growing cognitive incapacity, you know, on a course of Alzheimer's disease maybe, or other organ fragilities and physical problems, but also this problem about where they live is a piece of the vulnerability of these patients. And then the obvious questions about to what extent should this policy that they are talking about developing be tied to, be limited by advanced directives, particularly as patients have waxing and waning cognitive ability to talk with their caregivers about what they want and why they're doing what they're doing. And then what do you do around families who, you know, may have variable patterns of visiting, maybe more or less involved, and also staff who have, you know, who take care of these patients every day, some of whose intimate moments happen around mealtime and feeding, not just bathing and changing linen and taking patients for walks and so forth, but actually spoon feeding and being present in the room over time, where feeding is one of the ways in which we show that we care, depending on how we do it. And this possibility for a gap between who's making the decision about what's right for this patient and who's carrying out the decision that the people make. And then, and this sort of is what stimulated the whole thing, in previous cases, the ethics committee had said to themselves, among themselves, we can't have policy about not feeding patients. What would the public think? What if this, you know, this is Boston, what if this appeared above the fold in the headline on the Globe? You know, we're not feeding, you know, Hebrew Senior Life is not feeding patients, and they're dying, or even just one patient. And so that had been actually an impediment to the Clinical Ethics Committee developing, and I think perhaps correctly thinking that it's not a wise idea to harden things into a policy at the early stages of the institution and its ethics committee beginning to come to grips with this. But at any rate, this question of what would the public think came up in this case itself, but had been there all along, sometimes more obvious than at other times. So they came to us because we have something called the Community Ethics Committee. Now, where does a request like this go? Excuse me. Harvard has 15 affiliated teaching hospitals and long-term care facilities and an insurance company. And so one of the things many years ago that we set up was something called the Ethics Leaders Group. And we pulled together 4 times a year the chairs and co-chairs of the clinical ethics committees in all the affiliated facilities. So this is the one that brought this case, although we've had now 12 policy consults about what does the public think regarding some ethical issue. And the way they do that is come to talk to the ethics leaders group and say, we would like to engage the Community Ethics Committee in talking about their responses to the idea of, and advice and recommendations to the idea of developing a policy about how to handle patients who refuse to eat or drink, who live at our facility. So this is the first photo from the Ethics Committee, now 15 years old. You can tell that's not a recent photo since I'm sitting in that front row. Next to Carol Powers, who is the brainchild and implementer and leader of the Community Ethics Committee. And we described our mission as bridging the communication gap between health professionals and hospitals and the public regarding ethical issues in healthcare. So I should say that it's not specific to end-of-life issues, although I've singled those out because it has been far and away the majority of the kinds of questions that have come to the Community Ethics Committee, just like many of us discovered over the years of being in the action of developing clinical ethics committees, and the early consults were all around end-of-life care, where so much is at stake in whether patients live or die and how they live and how they die. So this group now has 10 women and 8 men, ranging in age from their teens. So we actively recruit a high school person from one of the nearby schools to their, I should say now 80s, we just had a birthday. And their educational background ranges from advanced degrees, including a PhD philosopher who's in the middle row there, high school diploma. Actually, in the first committee, we had a woman who had not yet finished her high school diploma. She was in her 60s then, she's in her 70s now, and she paired up with someone else on the Community Ethics Committee and finished her GED, which we all celebrated. Some of the members have disabilities, including a woman who has had 40 surgeries before the age of 4, who's sitting in the front row. Their languages include not only English, but 7 other varieties and 8 different religious traditions. And now 7 years ago, 2011, we went through the process of setting up a 501c3 to give more distance and independence to the Community Ethics Committee, and that's called Community Voices in Medical Ethics. So a number of issues have come up around setting up a Community Ethics Committee. Do any of you have any experience with looking toward public groups for input about ethical issues in healthcare, clinical healthcare? Through a community group, through a nonprofit, through...
Done lots of different ways, community group, but also just public advertising.
Yeah. So polling them on specific issues. This was, we thought originally about whether or not to do this more loosely so that we didn't have a standing committee. And one of the reasons we decided to go with a standing committee is because, talk about tapping a resource, and many of the people who are retired this is possible with, but many of the others it's not possible with. We wanted to be able to have some of these people serve as community members on the clinical ethics committees. And so they do that because a lot of our ethics committees didn't have community members. And I think we're still kind of uneven in our success around enabling community members to actively participate and be an equal input, conversationalist, discussant in some of those clinical ethics committee discussions. But at any rate, so some of the members of this Community Ethics Committee not only meet once a month to talk about the policy issues that we've asked for input about, but also have meetings at one of those hospitals' ethics committees where they get a better sense of from hearing case reviews, what the issues are at the hospitals. So this person, Carol Powers, is the co-chair of the committee, and her background is real estate and tax law. And she was on our ethics committee at Boston Children's Hospital, in part because she was one of the early, her son was in our intensive care unit from his birth, where he was transported across the bridge to Children's Hospital. We don't have a maternity unit until his death 10 months later. He was born with very little lung volume. There was a long period during which he had a number of surgeries where people thought that he might do well enough and grow big enough to be able to possibly have a lung transplant, and that didn't work out. And somewhere within the last month of his life, one of the issues that came up was the staff who were taking care of him beginning to feel like this just was terrible and they couldn't continue to do these things to him. And his parents remained very hopeful until very near the last few days of his life. And so apart from the ethics consult we had had midway around getting more information and having a better communication pattern that Carol and her husband Phil had asked for, was a staff request toward the end about, you know, how do we manage his care when a lot of people are objecting to continuing to be part of his team because he had to be resuscitated around his vent. So this is what Carol has gone through. And so some years after her first son died, she and I maintained contact, and she wanted to know, how the ethics committee that she had seen a little touch of was doing. And so I asked her whether she felt ready to and interested in being a part of some of those discussions as a parent who had had not only experience with what it's like to have a child in the hospital, but what it's like to ask for an ethics consult. And she did, and so she was on our ethics committee. As she had that experience and got very interested in it, she wanted to learn more. And since we have a fellowship program, she decided she was going to apply to do the bioethics, the fellowship in bioethics. And so this was the project that we proposed when she applied for a fellowship. And during her fellowship year, we set up this community ethics committee. So we had questions about how you find members. What we didn't do is gather the demographic information about the city of Boston and figure out what percentage of people were something or other and recruit on the basis of that. Rather, we just wanted to have some diversity, and we knew we wanted to have diversity in race and education and gender affiliation and languages and religions, and so we looked for that. Easier said than done. And then where it's located in the institutional structure, I told you we located it with the ethics leaders group as opposed to locating it with within the center. And we decided that this was a discussion we actually had in the early days of meeting with the first volunteer group, that it would be advisory. I'm not sure we had any idea how it could be any different, but I have been asked this question a number of times by groups in the public, why it doesn't have more authority. I don't know how we would get it, but, and then how people have access to it is kind of twofold. This has changed over the years. One is the ethics committees of the member hospitals can ask, as the first example I gave you demonstrates. And about halfway through, around the ballot initiative for medically assisted dying in the state of Massachusetts, the committee itself decided it could take up its own issues, which was an interesting discussion with the ethics leaders group. And so, so it's a combination of issues they want to take up and tell people what they think, and issues that the hospitals want them to take up. But the important point here is that when you set up a process for public engagement in the issues that we take up in our healthcare facilities, there has to be a robust mechanism for it to matter. You know, it's not just a matter of taking one evening a month and letting them sit around and chat and drink tea and, you know, tell people who may or may not listen what they think. That's just not good enough. So, over the years we have discovered that they actually pay attention and want feedback from the hospitals about what has happened to the recommendations that they have made. Did it actually change policy? And if it didn't, what didn't? You know, why didn't it? You know, what was it about what they said that the hospital just kind of said, thank you, but no, we're going to do it our own way. And then how do you get them ready? You know, these are people who range from no high school degree to a PhD. And most of them, except for one philosopher, don't have any background in ethics. And then how do you fund it? This is something we haven't solved the problem about. So we talk about the method. I'll come back to that. So we're, typical of me, trying to have it both ways. So we both want this cohesive group that actually gains experience over time in handling ethical issues that arise in healthcare. So that they gain expertise not only in handling the issues, but also in the ethical reasoning. And we want to have a kind of man on the street test of what people think, you know, depending on how you word the question. And so we have set up this system for a hospital to put in writing. They don't always do that. Every time they don't do it, it's a problem because, you know, if you haven't specified exactly what the question is and what you want advice about, the topic just kind of expands, and then people go, oh my God, they didn't really ask us that, and then it contracts, and then they start talking about it some more, and then they go off on a tangent. So it really matters to have it in a memo. I am surprised at how hard it is to get some of these committees to actually draft a memo and send it with a list of questions that they actually want public input about. And then the committee, any advice that they can give, the committee meets with them the first meeting and looks at the written request and any advice they have about what to read and ask questions. And usually that's more effective when we use a case or cases to describe the issue. The committee itself does its own search for information, and they get way different and more stuff than they were given, and they share it among themselves, now in Dropbox. I wasn't there in the early days. And then as they find themselves beginning to have this discussion and kind of going all over the map, they set up a list of questions that they want to be sure they know everybody on the committee's response to. And this is how we came up with the idea of having it both ways. So you know, in every group you've ever been in, there's somebody like me who goes, oh, and has something to say about everything, right? And then somebody who says almost nothing. And you have to actually call on them, and then they're very careful about how they say it. And so, in order to be sure we actually get the input of every person on the Community Ethics Committee, as we ask these questions, we have them fill out a survey. We use SurveyMonkey. They write in their responses. Some of them are yes or no or an easy checkbox, and others are more qualitative responses. And then we print those out, not with names attached, although you can often tell who said something, especially after the committee's been meeting for a few years. And we talk about the answers so that we have people getting closer together toward understanding where their major differences are and where they have some consensus. But we also have a survey we could ask people who are cold, who haven't just spent the last 3 or 4 months talking about the question they were asked. And so they can then send out this same survey through their Facebook page for people that they know and ask them to fill out the survey. So we have a comparison between people who have been talking about this for a while with members of the healthcare professions who have come and discussed their concerns, and people who are just asked these questions cold and can answer. And then we talk about those. There's nothing worse than writing a report by committee, and this is the committee that writes a report together. And they are incredibly patient and tolerant and encouraging of one another to get to a point where they've got language in a written report that they can all live with. And then that is sent to, once it's signed off by everybody, to the ethics leaders, and someone from the committee, usually Carol, comes and talks with the ethics leaders group about the report and the advice that they're giving. So that's the method. These are some of the topics that they have discussed. The stopping eating and drinking one was very hard. You probably saw from the pictures. We've got some people in there who are, like me, nearing the last quarter decade of their lives, maybe the last decade, and are actively thinking about this. We have a woman in the group whose mother was dying of Alzheimer's disease and other problems that she had during the time that we were talking about this. And so there's this mix of personal responses and examples from within their families, and an awareness that this is at the policy level for health professionals. And they were very sensitive to the fact that this case that they were originally given, this was not an ethics case consult, it was a case illustration of an issue for a policy that the committee was developing. Nevertheless, they were very sensitive to the fact that the patients who are refusing to eat and drink, for whom this policy would apply, are in a place that is their home. And so they were in consensus about not solving the problem by moving the patient before they were in anything near consensus about how to handle the refusal itself. And another interesting component is, and I've seen this before, that some of you who work around the area of clinical bioethics have too. So a number of times in the conversation, people would say, why is it that someone who is so sick doesn't know who they are and who the people who come to visit them are, and doesn't feel like eating and pushes it away, are the people who can't have this applied to them because it's voluntary stopping of eating and drinking. And even though people went over and over this ground, not from us, but because I don't advise this committee, and the faculty advisors who are there are not supposed to intervene in how the public thinks about this unless they're asked something specific. So they went over and over this territory of the common sense disconnect in their minds between letting patients who are not capable of making informed decisions refuse, and restricting this to patients who are able, on the basis of their cognitive capacity, to make decisions about refusing eating and drinking. I think they still have, not just on this issue, but on other issues, so pretty deep questions about that. But at any rate, they did think that it was appropriate for not only for there to be a policy that enabled this to happen, but also a number of people they thought should be involved, including palliative care and including the rabbi, since there are a variety of Jewish responses to the responsibilities of individuals to continue to preserve, make an effort to live, save their own lives. And also pointing out the importance of involving all of the people who are taking care of the patient in actually discussing what they're going to do, whether they're going to do it, and why they're doing it before they start to implement it. Because the persons who are going in and out of that room are the dietitian and the nursing aides, much more than the people on the ethics committee or the people, the physician, nurse, social worker, dietitian, nutritionist, etc., who might be ordinarily thought of as making a decision about eating and drinking. So then there are these others, and let me just say that almost every issue we've brought to this group, they have renamed. And this one is the one they've gotten most worked up about. So I realize I'm talking to an audience of people who probably have an interest in palliative care, as I do. But when it comes to talking about palliative sedation, I remember when this term changed from terminal sedation. Have you ever used this term, terminal sedation? Do you remember this? So it changed because that was such an awful way of describing it. To palliative, you know what palliative sedation is, right? Giving patients medication to make them unconscious and keep them unconscious. Probably not, almost never, varies a little. Providing medically administered nutrition and hydration during that period until they die. So when they were asked a question from one of the hospitals about palliative sedation, the first thing they did is, and some of them were pretty outraged about this, discuss how untransparent to the general public that term is. Now, I know that we can describe what it means, but you know, there were advocates, there still are advocates on the Community Ethics Committee who feel very strongly that people should say what it means. And so they developed this, I might not even be able to remember this, I looked it up this morning, but it's long. Providing medicating patients to unconsciousness until death. So that people know what it means. And they weren't opposed to the idea. There was no, you know, kind of response to that. It was just unpacking the palliative sedation term and being candid about the difficulties of taking care of patients who are suffering at the ends of their lives and whose pain isn't easy to manage and who would prefer to go to sleep and not wake up. So those are, you can find these on the website. So I want you to take a minute or two to just talk to the person next to you about whether there is any ethical question. How many of you are clinicians? I may have misjudged who's here. Okay. Whether there's any question in your clinical work that has caused you to wonder what the public would think. Because I'm going to ask you for input in a couple of minutes. But I would actually, if I say this and we don't talk, nothing happens. So I'm going to ask you to talk to one another and try out a couple of ideas so that I can get some feedback about what kinds of things in your clinical work you might want to have public input about. Okay. I know that wasn't very long. What did you come up with? I want to see whether we've actually dealt with some of these. Anything you came up with that you could imagine if you had a community ethics committee asking for public input about? Yes?
Hospital capacity in the ICU dependent patient.
I can't quite hear you.
Hospital capacity in the ICU dependent patient.
So hospital capacity for
In the ICU dependent patient.
the ICU dependent patient. So how should, this is the rationing word that people hate to use, and we have only dealt with around a study that we were doing regarding shortages of what we came to call stuff, staff, and supplies. Not staff, and I think I got the third one wrong, but anyways, and this had to do with what the criteria would be for who did and who didn't get it. And so this issue of patients who are ICU dependent can't live unless they're in the intensive care unit, although we do send some of them home. It always amazes me that they can't live on the floor, but they can live at home. And hospital resources and patients who therefore don't have access to the bed that they're in, right? Wouldn't that be interesting? I absolutely think we should be asking the public about this. And partly because it's very hard for our departments of public health, at least in my state, to take it up. And so one of the things our center has done is try to give them arm's length distance from the rationing discussion, so that, you know, because when the public gets upset, or the press gets upset as a reflection of what they have heard some people in the public say about a public health issue, the first thing that you hear in the interviews with the governor is whether or not he's going to fire the DPH commissioner. And they have done that. So any DPH commissioner has to at least think about what the public response is going to be if they take up anything least bit controversial. And this is pretty controversial. And so one way of giving DPH itself and the political mechanism a little bit of distance is to run a public deliberation process that gets some public input. Although it's really interesting to start asking the public about some of these questions and figuring out how you adequately educate them about the things to take into account, and what the line is between education and influence as you try to give them enough information to actually grapple with the issues and have enough knowledge to make informed recommendations without trying to tell them what you wish their recommendations would be. Yeah, good example, very good example. I wish we did more of that. And there would be a number of end-of-life issues here that have a rationing component to it that we could think about. Anything else? Yes?
The ethical issues of a mom with HIV delivered here, from Africa delivered in America, who would like to breastfeed.
Yeah, and I think that's a hard issue. One of the things we've talked about is not only the distinction between individual case consultation. So the example I gave you was just an illustration of a case to enable the committee to get their teeth into the issue and understand it, but not give advice about that specific case, both because talking about it would have been a breach of confidentiality in enough detail to really, because circumstances matter and ethical reasoning, right? So that's one piece, the difference between an individual case that you're asking for public input and a policy issue. And this could certainly be a policy issue. And then there's the problem of clinical decision and knowing all of the clinical information. This has come up around, you know, trachs at the end of life versus not doing trachs, or trachs and G-tubes and so forth. To what extent is that something that falls within the domain of clinical practice for which certain kinds of expertise are essential to making the decision, and it isn't really enough of a ethically gray zone that it belongs in the Community Ethics Committee. And I'm not sure where this issue falls around. I understand about the difference in decision-making authority and responsibility between the United States, where this has been, you know, it's not okay for HIV-positive mothers to breastfeed their babies, and Africa, where it is. So there's a difference in whether mothers can decide here or there. And then there's that question about, is this something that should be dealt with by medical expertise or dealt with by values expertise? And that's a tough one. Okay, I'm going to just tell you a little bit more about where there's more information regarding this before I wrap up for questions. One of the end-of-life issues that is being increasingly discussed in our hospitals, who went through the first wave of ethics committees writing policies regarding decisions not to resuscitate, is revising those policies that have had a requirement that patients, more likely their surrogates, or in pediatric hospitals, their parents, have to give permission for decisions not to resuscitate, or have to not only know about it, but consent to it. And our hospital, we weren't the only one, but went through a process of revising our policy and selecting out those, not very frequent, but nevertheless they exist, cases where it is not therapeutic and a patient is clearly imminently dying and it's not therapeutic to do CPR, and yet this is a situation in which a family just would not be able to say it's okay not to do CPR. And so it contains language, the revised policy contained language to enable a clinical team to do. This is another one in which the Community Ethics Committee revised how we talked about this. Unilateral DNR is how the clinicians refer to it, right? It's very efficient. But it is so unfriendly as language. And so this was one of the ones that came to our Community Ethics Committee for discussion. I think it's a pretty unresolved area in a lot of places. So here are some of the challenges. It's very hard to decide who belongs on a public committee, and you want a group of people who can work well together and respect and influence one another, and yet you want diversity. Hard middle ground to find. We dealt partly with the ethics education piece by enabling the committee always to attend our 3-day intensive clinical bioethics course for free. We charge the rest of the world $1,000. We don't pay our Community Ethics Committee. I'm not sure that's the right thing, but it's another issue. And this is one of the things we do have them come to that course. I've already told you we've had some difficulty getting the askers to narrow the question and be very specific about the questions they want input about. I just mentioned this difficulty of making sure they understand the issue but not telling them what to say. We have not always done the second phase of our methodology. So the committee itself has always ended up figuring out what they think and writing it up and giving it to the ethics leaders. But they have not always included that second step of sending a survey out to friends of friends through Facebook. Not a rigorous public method, but at least it gives you an indication of what some self-selected portion of the public thinks cold on an issue. And here's the one that's troubling me now, and which I hope we're going to spend some time talking about with the doctoral students. What is the normative standing of public advice? So we've had a few things in bioethics where we've said, you know, kind of on a grand scale, this is something we should get public advice about. And when you start reading the requests for proposals and you start seeing the grants that are written that contain something that says, and we should have a component about getting public advice. But nobody's talking about what you do with that advice. Like, what if it doesn't agree with what's beginning to emerge as a consensus among experts? Does it have, in a couple of cases, it has had veto authority. It stops things cold because, depending on the method used, getting public input has gotten people to the point where they just said, no. And then a plan to go forward with some kind of research or therapeutic intervention or something has stopped. So this is an area I think we still need to do some work in, figuring out what the weight of this piece of the discussion. And, you know, this is probably going to involve some better clarity about the stakeholders and the level of involvement and so forth, but I think this is an area we need to do some work on, and a couple of us have been talking about how to do that. And then another is how you support this kind of work, because it turns out it's a ton of work. And Carol has given the bioethics community at Harvard a lot of time, and by leading this committee, developed a level of expertise that with the Community Ethics Committee that has been very valuable. And yet, to the extent that you pay them and they become employees, they suddenly have a different kind of standing, and people often ask whether they're paid. And if they're paid, somehow that, you know, I don't know why it is we can't pay people for values information, for values advice, but it's pretty common. I work on a very $1.3 billion project in Europe where only people in this project who aren't paid are the people on the ethics committee. And it's because we've absorbed this idea that paying people for information about their values is somehow contaminates what they say. So this is where their weblog is. You see they're using their nonprofit named Community Voices in Medical Ethics. They have a Twitter account. This is Paul McLean, who's on the committee. He is a former journalist from Southern California who's moved to Boston and has since taken a fellowship and does a lot of the tweeting and blogging. This is their Facebook page and their Twitter account. So I'm going to close there by just saying, never doubt that a small group of thoughtful, committed citizens can change the world, at least our little world. Indeed, it's the only thing that ever has. Thank you.
Oh, okay. So we've got one microphone, and Alan will walk to you so we can capture it on the recording. Right here, if you don't want to walk far. Even if you do want to walk far.
Thank you so much for this one.
Yes, excellent. Thank you so much. That was a great talk. I'm not a clinician. I'm a basic scientist by training. All my stuff is around emerging biotech. So I have lots of questions about public engagement. I'm very interested in public engagement, but in a different sphere, right? So, and I completely agree with you that the piece that I don't think anyone has satisfactorily figured out is how to transfer whatever comes out of a public engagement process into the policy-making process. Unsolved. The question I want to ask, though, is about selecting the people. I've done a lot of consensus work, and it's very important that the people around the table play nicely together. And I mean, regardless of what their background or the demographics, right? They need to be genuinely thoughtful, willing to engage people. How do you vet for that?
Personal interview. And Carol, I used to see them all. Carol sees them all. We have a process of application to serve on the committee. So people actually have references. And we have called references a couple of times. Because I agree with you. You get some people in the same room together and they're going to fight no matter what the issue is. It could be about whether they let the dog out. Yeah.
I have a question. It's not very well formed. I guess I just want to hear you think out loud about it for a minute. You made this interesting point that the committee members are allowed to take your intensive courses for free. First of all, I guess I just wonder how many take you up on that, if they take it multiple years. But the more kind of theoretical question that I wonder about is, I guess I had this sense that when we want community feedback, what we want is something like uncorrupted feedback, right? All of us who are around the table all the time are corrupted in important ways. But the more we offer training to people doing this, like the more we kind of corrupt them. So I guess I just wanted to hear you think aloud about, you know, pitfalls, positives and negatives, kind of if you've had that conversation.
Yeah, good question. So you're right. And one way you try to correct for that is by having terms and rotate out the committee. And I have been utterly unsuccessful in we didn't build this in, and we should have. We thought we weren't going to get people. And so we didn't even think about the fact that they could only serve 2 years or whatever it was going to be. And we've still got some people on this committee who were there from the beginning. Now, you're not supposed to be involved in healthcare in any way. So we had a member who eventually ended up in his rabbi role working with a hospice. And it's partly because he got very interested in doing this work while he was on the committee. And yet, when I went to, Carol approached it first, told me he'd never leaving. And so I had tea with him, and he ain't leaving. And you can just kick people off, and I just wasn't willing to go there. But it is a problem, and we do have groupthink, I think. And this is still a work in progress. I don't at all mean to be telling you this is the way to do it. But I think having terms and then, interviewing people, having an actual serious application process and vetting people and interviewing them and telling them right up front, we want you to be able to speak in a group and take a position that maybe everybody else doesn't want to take, but do it in a way that, and play nicely with others, is exactly the way Carol says it. And that's, not everybody can do that. And that is something this committee has figured out how to do. They've done it really well. So you can actually find all their written reports on our webpage. You can click on them and see what they said about medically induced death, which is their word for medically assisted dying.
I think we have to leave it at that, unfortunately, but thank you very much. And just remind everybody that our next seminar is the 26th. Hildy Lindemann will be here from Michigan State University, and that will be in Feinstone over in the Wall Street building. Thanks, and we'll see you then.